Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent and reverse brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a functional medicine physician in Cleveland, Ohio, and your host on this journey. So, whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have loved ones with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's and dementia. If you have questions or comments or just want to connect, please check us out on our Facebook page, or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. So here we go. Let's get better. Welcome back to the show. The title of the episode this week is a little provocative. Is Alzheimer's a myth? Bottom line, if you ask anybody, any family member with someone suffering from Alzheimer's disease, they'll probably tell you that Alzheimer's is a real deal. But our guest today has written and spoken extensively about what he calls the myth of Alzheimer's and authored a book with that name. Dr. Peter Whitehouse is an MD, PhD, trained at Johns Hopkins, and currently a professor of neurology at Case Western University in Cleveland, Ohio. Please welcome to the show, Dr. Peter Whitehouse. Welcome, Peter.
Thank you, Nate.
It's great to have you. You've done a lot of work. We sort of initially met by phone through a mutual friend of ours, and I've been fascinated with your work for a few years now, certainly since I came to Cleveland and was still training. You wrote this book, Myth of Alzheimer's, and I think the veracity of the claim in the book is largely based on your own personal extensive research background and experience in the field of neurodegenerative diseases, particularly around Alzheimer's. Can you just tell us a bit about your background as a clinician, doctor, and researcher?
Sure, I'm happy to. So I trained at Hopkins as an MD, PhD with a PhD in cognitive neuroscience. I did some of my early work on schizophrenia, then stroke, and eventually ended up working in the neuropathology of Alzheimer's disease. That included work on cholinergic systems, eventually led me into the drug development area, then moved to Case to create the Alzheimer's Center here, as you mentioned.
And how long have you been in Cleveland at Case Western?
A little over 30 years now, Nate.
Wow. All right. Time's moving. Can you explain how you sort of came on, at what point in your career you came on to this idea? Because you were, as you write in the book, a real, and as you're known in our, the Cleveland community, definitely a thought leader in terms of aging and Alzheimer's. And you had, at some point, you were advising drug companies and, drug strategies. And obviously that's a very kind of traditional research and clinical role. When did you adopt this idea of Alzheimer's being a myth? Can you explain what you mean by that and kind of how you broke ranks, so to speak?
So the recognition that Alzheimer's, in my view, wasn't quite what I thought it was earlier in my career, and when I deviated from the mainstream, was motivated by a number of different things. It was working clinically, and it was working as a researcher. When I came to realize the incredible variability and heterogeneity, that was at a genetic level, a pathological level, a clinical level. And so I came to feel that Alzheimer's disease as a singular noun no longer really captured the reality of the experiences that I was having with my patients and learning from the research data.
Okay, so maybe what you're saying then is what you've come to know Alzheimer's disease is more of, what's more of a sort of a syndrome, kind of a multifaceted, heterogeneous sets of conditions. So it's not just one thing, it's multiple things that we just end up being called Alzheimer's?
Yes, that's right. As I said, that heterogeneity is at many, many different levels of understanding of this syndrome, as you well put it. I think the other thing, Nate, that I came to recognize was that the easy way of separating Alzheimer's from the processes that we considered as a normal part of the aging brain was not so easy. And I worked on a variety of different approaches to try to characterize the spectrum, which I now believe it is, And of course, really, it should be spectrums. So there are a lot of biological processes going on in our brains. And unfortunately, some people's brains age faster than the rest of their bodies, and they then develop dementia.
So do you see, there used to be a term that was used more commonly, senile dementia, and when you sort of expect if somebody's 95 or 100, that they're slower, that not there, maybe great grandma's not all with it, or grandma's not with it, or dad's not with it, like he or she used to be. Do you see a distinction between the notion of senile dementia and Alzheimer's disease, and let's say somebody that gets it when they're in their early 70s?
Well, I think first, as you know, and Alzheimer originally described what came to be called Alzheimer's disease in people even younger than 70, in their 50s. And this was what Alzheimer's disease originally was, a pre-senile form. But the more common forms, which really overlap with other conditions, do tend to get more common with age. So the time in your 80s and 90s, I think it's fair to say that more people than not have enough cognitive impairment that they would be considered as having dementia. So 70 is kind of in the middle. I mean, it's also our conceptions of 70 have changed. That's the kind of young old.
Well, this is the loaded question. I fully admit, Dr. Whitehouse, this is a loaded question I asked.
Well, it's not a loaded question. It's true, because I think the most controversial thing about the position we've taken is that there is no clear way, whether you're 70 or 80 or 90, to separate out what we have come to call Alzheimer's diseases and all their variants from people that are just having, a bad case of brain aging. The biological spectrum, the clinical spectrum, they all overlap. But the most important point, I think, in this regard is that, by the time you are in your 70s, 80s, and 90s, there are many things throughout your entire life course that could have affected your brain process at that later stage in life. So we're coming increasingly to recognize that chronic traumatic encephalopathy, even mild degrees of head injury, can contribute to how well your brain is functioning when you're older.
So things like concussions and brain injuries and things like that, and certainly in football players and, and a lot of other people that we see. But do you have, in the way you see it, do you see any other kind of key drivers, especially for non-senile, so earlier onset, so people that are getting this in their mid, late 60s, early 70s? Do you see, or do you have experience with putting forth kind of this concept in terms of earlier onset? What are the drivers as you're seeing them?
Well, I think in those early onset forms, genes tend to be drivers in many cases. Those are the autosomal dominant forms of pre-senile or early onset Alzheimer's disease. So I would mention genes. But I think increasingly my concern has taken on a kind of public health perspective. So exposure to environmental toxins early in life and even later in life can be a cause, lead being the kind of prototypical example. And, increasingly lifestyle factors like diet and whether you exercise, all those kinds of things can come into play when you have an early onset form. There are also rarer conditions. You can get Jakob-Creutzfeldt disease, you can get brain infections, you can get chronic meningitis. So when you see dementia in somebody earlier in life, there's a wide range of other medical conditions that you have to consider, as well as these lifestyle factors that I've suggested.
Just out of curiosity, I'm now seeing a lot of people that have been diagnosed with what I also regard as kind of syndromic picture, where it's a spectrum, like you mentioned, or spectrums. And oftentimes they're younger, and they do not carry one of the pre-senile genetic forms of Alzheimer's. And these are often not running in their family, but on MRI or brain imaging, or when they get a spinal tap done, lumbar puncture, they'll have these signatures that are consistent with, though those are controversial a little bit, but they're consistent with an Alzheimer's picture. So they've been diagnosed with Alzheimer's, as it were. And it's not at all clear what was the trigger. However, in many cases, and I'm asking this more just to see what you think in terms of your experience. And a lot of times I see post surgery. People had general anesthesia. They've had it maybe once or twice, especially in a short course, a number of months. They had a joint replaced and then something else done. And that seems to be a contributor not every case, certainly, but in more than a few cases. Do you see that as well? Anesthesia being it's certainly known to cause delirium and things like that, but as a potential trigger or co-contributor to the development of cognitive impairment that's being called Alzheimer's in some cases?
I actually agree with you, Nate. I do think that general anesthesia can contribute to cognitive impairment that's a bit more than just the postoperative delirium that you mentioned. I think that depends on the duration, depends on concomitant medical illnesses, it can depend on what the surgery was for. If there were complications like hypoxia, things like that during the surgery, then obviously there are other surgical factors that can contribute to that postoperative cognitive confusion that doesn't lift as readily as we'd like to see. That said, of course, there is good reason to have general anesthesia. It's a blessing for people that do require, surgery. But I would say, particularly in an older person, that it's no longer appropriate to kind of not consider into the equation the fact that a general anesthesia may contribute to a cognitive impairment that doesn't as readily.
It's interesting to hear everybody's observations. I ask a lot of people that, especially people like you who've had a lot of experience, just to see what they've seen over decades of practice. When your book was published, I think the book was originally published over 10 years ago now, The Myth of Alzheimer's. How was it received, and how has the landscape changed at all in the last 10 years in terms of the notions that you put forth in the public over 10 years ago?
So that's an interesting question. So the book, I would say, got a wide range of responses. The Alzheimer's Association didn't like it because even before they read the book, because the title itself is provocative. Obviously, we're not suggesting that people don't develop memory problems as they get older. It is a common and a huge challenge that we need to meet as individuals and family members in society. But we were saying that capturing this under a single label, Alzheimer's disease, was misleading us. And I will say the book not only challenged the notion, but also suggested that if you think about these conditions differently, your approach to clinical care is different. There were a lot of people that resonated with that we shouldn't be just pushing drugs on older people, that we should be taking a more comprehensive and holistic approach. Next question, though. I actually believe, and of course I'm the author of this book, so I'm inclined to look for the evidence to support it, but I actually think it's quite clear that the message of heterogeneity is very much evident. Many, many people now are talking about Alzheimer's as a syndrome or Alzheimer's disease as more than one thing. So I think that point that we made, and we weren't the first to make the point, we were just perhaps the most provocative, that has been confirmed. I also think that despite spending billions of dollars on attempts to develop diagnostic tests and biomarkers, we still cannot easily differentiate the normal changes that would occur with aging from processes that we call Alzheimer's. So I would say that second message, that it's not clearly separable from aging, has also been confirmed by the absence of people finding definitive tests. Claims for definitive tests are a dime a dozen, but they just don't pan out.
I see. So that's kind of the diagnostic side. How do we distinguish by looking at someone's brain or looking at someone's spinal fluid or looking at someone's blood, et cetera? How do we determine if what is going on with them is Alzheimer's versus Alzheimer's A versus Alzheimer's B versus Alzheimer's C versus something else? But like you mentioned, hundreds of billions of dollars have been spent on looking for a medication cure, like a kind of a classic pharmaceutical drug. Certainly, if there was one, I think we would all be running to write for it for our patients, because right now there really isn't much. What are your thoughts as, again, having deep experience in the world of trying to find a cure, chasing the cure, and treating people? What are your thoughts on, every few weeks or every few months, it seems that we see another article saying, yeah, we're 10 years from a cure, we're 2 years from a cure, we're 5 years from a cure. We had a really good result in a mouse that the mouseheimer's, the mouse that has Alzheimer's. And what are your thoughts on finding a cure? Do you think the notion of finding a so-called cure is overly simplistic?
Absolutely. Finding a cure is overly simplistic. I mean, if we just connect that to what we've been saying in the earlier part of the conversation, that Alzheimer's is not one thing, then I sometimes say, well, how many different cures are there that you're expecting to find if we've got a lot of variety in the conditions we're currently labeling with this single noun, Alzheimer's disease? I also think it's irresponsible of people at the National Institute of Health and at the Alzheimer's Association who keep making these claims that we're just that close. And there's going to be a crunch in 2025 because that's when they promise that they're going to have an effective therapy. What they say, is it a cure? Is it an end to Alzheimer's disease? Is it prevention? Whatever the term they use. But it's very clear that, as you suggested, Nate, you can go back, and I've been in it for 30 years, and find people that said we'd have something the next year, starting 30 years ago. So I think there's this incredible fear-promoted scientism. That is a religion. I'm a scientist, but I do not have the faith in science that if you just pump enough money into a field, you're going to find the answer. And that is what the Alzheimer's Association has been, in my mind, irresponsibly claiming for too long. And the other reason it's irresponsible is that we are now finding that there are things we can do to improve the quality of life of people with dementia today and prevent dementia. That's becoming quite clear. There are places in the world where the incidence of dementia is going down, the age-specific incidence. And that's probably because of public health measures, not because of any drug.
So in your book, you lay out some of these kind of multi-layer approaches. You've mentioned omega-3s and alpha-lipoic acid and some other types of pills you can take. But you also talk about integrative modalities like yoga and meditation and acupuncture. So, I mean, since you mentioned even in broader terms like public health measures, can you speak a little bit about the benefits of some of these kind of what I would call in maybe in the United States non-conventional modalities that you think may be having some role in either the prevention or slowing of the process of so-called Alzheimer's?
Yeah, I think this is a very difficult area because the epidemiological evidence suggests that there are places where, as I said, although the evidence is not clear what they are, public health measures can reduce the incidence of dementia. And that probably in part because of vascular risk factors, because we've come to realize that some of the risk factors for heart disease and stroke are risk factors for Alzheimer's as well. But I personally believe that the evidence that physical exercise, keeping your body active, the brain health is not separate from body health, is really important. The evidence around specific diets is not clear, but I think to suggest that a diet that lower in saturated fats and higher and lower in carbs and higher in fiber and fruits and vegetables. So some people call, some of those diets like the Mediterranean diet gets a lot of press. So there are factors that suggest to me that diet is important. One area that I'm particularly interested in is cognitive activity, brain fitness, brain games, because there's a lot of hype associated with them. My wife and I started 3 intergenerational public schools where people with memory problems come and work with kids. And we have some evidence, but it's hard to get this kind of evidence, that people who keep their minds active by doing meaningful, purposeful work in community, that to me is the most important thing you can do with your brain, which is to keep learning and learning with others and learning in a situation where you help others.
I'm so glad you brought up the Intergenerational School. Can you just kind of tell the listeners what that is and what's involved in that and how that's set up? Because that was one of the things that first attracted me to your work.
Well, thank you. It's been a work of passion and purpose for, the first school started in 2000, so over 15 years now. So my wife is a developmental psychologist, and as we've been talking, I'm a geriatric neurologist. She evaluated children with learning challenges and came to realize that she could have more impact on those kids as an educator, as somebody who could create a learning environment rather than individual practice as a psychologist. Similarly, I came to see that the overemphasis on medications, medical model was not adequate for for aging. And so we started one school in 2000 as a public charter school. And basically the relationships that the kids have with elders include when elders come to the school and work often one-on-one with children. Our signature program is reading mentoring, but there are activities as well. Or when our kids go to long-term care facilities and work with groups of residents there. The basic point, though, is the kids have one-on-one relationships that help build confidence, that are fun, and that often are based around sharing stories.
Well, so stories. So in your book, and I've heard you also talk publicly about people writing their own narratives. There's organizations like Storycorps. And can you talk a little bit more about this idea of the value, first of all, defining what this idea is of writing your own narrative, and then what are kind of the practical values of those that you've seen?
So I think that stories, narrative is a much undervalued activity in human life, and undervalued when it comes to health care particularly. I think whether people feel healthy or not, and whether they feel their life is meaningful or not, largely depends on what stories they tell themselves and others about what their life is all about. And that is what happens in our schools, that the kids interview the adults and the adults talk to the children about what's going on in their own lives. I'll give you one example, and it's an area of learning that I think we all have to pay more attention to, and that is our relationship to nature. So one project that we did was our kids interviewed elders who had been politically active in the 1960s to save the nature center that our kids go to. It happens to be located in Shaker Heights near our school. And we published this as an article on passing activism across the generations. And that co-learning where the elders shared how they had protected the nature center earlier in their lives hopefully passes on a sense of responsibility to the kids, that they too have responsibilities for future generations and to maintain the quality of the environment. This, I think, is a huge intergenerational ethical issue, the fact that the planet has real problems with its health, and we're responsible for that.
Yeah. Oh my gosh. Yes, absolutely. And I think actually my children still visit that nature center that you're referring to and have come to view it and feel about it, that it's something special in their lives, no doubt. So that sort of transgenerational give and take, because it does sound like it's bidirectional, because the kids are also going into nursing homes and that, but that sort of transgenerational wisdom does seem to be, at least here locally, it's working. So can we just talk a little bit about the idea of writing one's own narrative and what it looks like? So Storycorps is something that comes up in the book. What exactly you're proposing for people to do, let's say, even outside the context, are you suggesting that people kind of write their own narratives independent of interacting with others, even just for themselves, almost like a journal? Or does it always have to be kind of something that's more intergenerational?
I think it doesn't have to be intergenerational. I think it doesn't even have to be social, in the sense that I believe in the power of journaling, that people can write for themselves. Although when people journal, they tend to write about other people anyway. So whether you're writing by yourself or whether you're sharing stories collectively, I think you're always telling stories in relationship to other people in your lives. And it doesn't always have to be just a diary where you're telling true stories. Timeslips, developed by my friend Ann Bastings, who got the MacArthur Prize for this work, is a group storytelling process where you make up fanciful, fictional stories. Her method is she shows the group a photograph that can cause some puzzlement. I like the one of the elephant sitting on a park bench next to a child. So the basic idea is that then the group starts making up, well, what's the name of the elephant? What's the name of the child? This works very well with people with dementia because there's no one story that is the right story. It's just whatever the group makes the story up to be. So it can be solitary. It can be pairs, it can be small groups, it can be fiction, it can be nonfiction. I do think that the intergenerational storytelling adds an important dimension potentially, and that is time. What I say all the time is that kids get the opportunity to see the past through the eyes of the elders. The kids were not alive. So when we had volunteers talking about what it was like to march with Martin Luther King, yes, the kids can see photographs and the kids can read books, but to hear it from somebody who was actually there just brings it alive. And equally, what I say is that the kids give the elders the opportunity to imagine the future that they will not see, that the kids may see, so that there's this notion that the elders get some connection to the future because they're working with kids who will likely be alive in that future. So this idea that intergenerational storytelling has this temporal dimension, I think, is an important aspect for me, because I think human beings have got to learn to think long term. That's our short-term focus, is why we're into some of these complicated planetary health issues we've mentioned before.
Yeah, so the macro element to this is beautiful in terms of transgenerational, and then how it manifests out into or flowers out into kind of the health of the world, as it were. Do you find that telling an elder, telling their story is therapeutic for themselves? Sort of just having someone to talk to in a sense of a story rather than sort of in a, this is your therapist type of arrangement, has value in and of itself therapeutically?
Yeah, I think so. The word therapy there, I'll come back to it in a minute, but I'll mention, an early mentor of mine, Butler, was the first director of the National Institute of Aging, to help develop reminiscence therapy. So that's what we're essentially describing here, which is the opportunity for someone to look back through their lives and to recount events and to share them with others and to reflect on them. I think this is healing in a very broad sense. It gives us people a sense of connectedness, a sense of cohesion, again, a sense of holistic health. So I hate to make it therapy, which tends to sound more medical and more psychological. I think stories are things that can heal not only individuals, but also communities. I work with a man who wrote a book called Story Bridge, Richard Gere. He goes into communities and he collects the community stories and he makes a play that the community performs. The subtitle of his book is From Alienation to Action. So this idea that recounting, looking backwards at the positive stories that a community can tell about itself and using those stories to create a positive vision for a community is really powerful. He's done a lot of work in Malaysia, where there are a lot of storytelling traditions and also a lot of communities that are challenged by poverty and other things. So I absolutely think that storytelling is therapeutic, it's healing. I also think, last comment about this, that a lot of what we're facing in the world is a spiritual crisis. Human beings are realizing that there are huge challenges in the world, that we are contributing to the loss of other species, and that our species and our civilizations are actually threatened. So I think hopeful, positive stories about what we have accomplished and how we've worked together to collaborate on solving problems in the past will perhaps be the most important thing we can do, creating more positive stories for the future. And I like to think of our intergenerational school as a kind of narrative engine to create those kind of life-affirming, future-oriented, hopeful, positive stories.
Well, that's beautiful. You also, I've heard you talk and read from you that in terms of what the generation that has the most experience has to give those that with less or the least experience is certainly important. But I've heard you kind of theorize on why you think maybe the baby boomers are uniquely qualified as a generation, sort of as a generational phenomenon, to kind of change the discussion around some of these therapeutic storytelling, non-medical, just the idea of healing and becoming more whole, but change the discussion around healing and becoming whole and even around just general aging. Can you talk a little bit more about your thoughts on that?
So I am a baby boomer and I have complicated feelings about this. We just edited a whole special issue of a journal called Generations on Gen X. and I work with a lot of millennials. So the first thing I'll say is I tend to think we can overdo these generational identification. You are a millennial, therefore you have these characteristics and so on. So that said, I think the theme of that special issue that I emphasized was, and my co-editor was an African-American woman, Gen Xer, so the two editors had those different characteristics. But the thing I emphasized was how important it is you can't work between the generations. So I think baby boomers, because we are large, although not as large now as the millennials, do have a particular responsibility because during our watch, things have begun to deteriorate. You could say that began to deteriorate earlier than even the baby boomers, but the idea that we have been alive when the number of people on the planet has grown so rapidly, when we've consumed natural resources irresponsibly. So yes, I do think there is a special responsibility that baby boomers have to working collaboratively with other generations to try to address the problems that our generation has a big hand in creating.
As we kind of wrap up, we've talked a lot about big things and also about kind of smaller, local, practical things. If if somebody comes to you today and says, Dr. Whitehouse, my spouse or my father, son, mother, brother, whatever, has what we think has been diagnosed as kind of early Alzheimer's, what can they do? Bottom line, kind of most practical, 3-4 things. What would you sort of prescribe for them, given your view, that you think would be most helpful?
When the people come to see me, they often had other attempts at diagnosis. And I think that makes people really confused and really sometimes sick with doctors because they often get told, while you've got Alzheimer's disease, there's nothing we can do. Even today, that's been. So I think the first thing to do is to explore what the label means to them and to, as part of that conversation, make it clear that there is a lot of heterogeneity, just what we've been talking about, Nate, and that the rates at which things change vary amongst different people. And then to move quickly from, we don't understand all these conditions medically, but there are things we're pretty convinced you can do in your own life to minimize the impact of this. And that is to keep your body healthy, to exercise, to stay socially engaged, to stay cognitively active, and in my view, with meaningful activity that gives you a sense of purpose. And that in exploring what this label means, you can still find and use this process of having memory challenges as a way of actually deepening your life. I actually think that Alzheimer's is far more important than Alzheimer's because if we really try to figure out what it means to begin to lose your memory, with a lot of uncertainty associated with that, it will allow us to do work exploring our own individual and family reactions to it. And I'm part of the National Advisory Board of Dementia-Friendly Communities, which is part of age-friendly communities, which in my mind is part of friendly communities in general. So that's to say, we will, as a species, do better when we learn how to address with humility these challenges of aging, which unfortunately do include, for some people, significant memory loss. That was pretty long-winded, but basically what I say to individual people is don't worry so much about the label. Doctors really don't understand these labels. Go out and live your life with a degree of zest and zeal that will have the rest of your life be as meaningful as it possibly can be.
Well, that's excellent. Peter, it was an honor and a pleasure to have you. Thank you so much.
Nate, thank you very much. Appreciate the opportunity.
So that's our episode. I hope you guys got something out of that. Check the show notes out on iTunes or on our website where we've summarized the key points. If you have questions or comments or just want to connect, please check us out on our Facebook page. Or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. Finally, if you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. Thanks, and talk to you next time.